And today we have the pleasure of having 3 of our county's physicians on this call, in this forum, to talk about preparing for end of life. I was thinking this morning that there are so many steps that people take when they are about to give birth and have a child. Pampers Diapers has a list of 21 things to do to prepare for birth. There are lists out there, I think today, about the fact that in May, so many people are graduating from high school and college, and I know parents are looking at lists or thinking about all the things they need to do to prepare their children for the future. So planning helps us meet the expected and unexpected times in our lives. We have talked a little bit about end-of-life planning in our forums, and we've talked about the legacy that people may want to leave. We've talked about creating life stories, legal planning, creating that power of attorney or living will or POLST or designation of guardians. We did a forum on body disposition, creating services, celebrations, and Swedish death cleaning. So I think we've covered the gamut, but today we're getting into a really important area. And I will let our moderator, Lael Duncan, Dr. Duncan, go into the specifics and frame the conversation. But let me do a quick introduction to our 3 speakers. Our moderator, Lael, or Dr. Duncan, is a colleague and a deputy health officer in the county of Marin. And she has worked on prevention of infection in facilities, and that looks after the health and wellness of our community elders, especially in those long-term care settings. She has developed a curriculum for the POLST program, and you may hear about that POLST if you don't know about it. I'll hear about it a little later. She's very familiar with decision aids for end-of-life planning and treatments. So she is going to moderate the conversation between Dr. Catherine Madison and Dr. Joshua Biddle. Dr. Madison is a board-certified neurologist who specializes in dementia care, and she served in the Air Force. She also cared for her own mother with Alzheimer's disease. So she's going to bring a personal perspective to this conversation, as I imagine many of you on this call could also contribute. She's an active member in the community, working with the Seniors at Home program at Jewish Family and Children's Services. She supports clients that have cognitive impairment and their families as they navigate the challenges with dementia diagnosis and end of life. Dr. Joshua Biddle is a palliative care physician leading our Marin Health Outpatient Palliative Care Program. He is a big advocate for whole person care, and I love to hear that word in any element of our supports and services of people and residents. He likes to address all forms of suffering, including the physical, the emotional, the psychological, and the spiritual, that whole person. He mentors palliative care fellows at UCSF, and is also interested in the use of psychedelic medicines to treat existential and psychospiritual distress in patients with serious illnesses. I don't know if he's going to cover that today, but I think all of those bios may give you some ideas of questions that you may want to pose at the end of this or within the context of this forum. So with that, I'm going to switch to speaker view, and we will come back to group view, gallery view, when we have our Q&A. Okay. In the meantime, as questions come up during this forum, please put them in the chat. I will be tracking those and making sure they get answered. So you don't have to wait till our Q&A to come up with your questions. Please keep a running list of them. And with that, I'm going to turn this over to Dr. Duncan and switch us over to speaker view. Dr. Duncan.
Thank you, Sarah. Welcome, everyone. We're all delighted to be here today and share some really interesting and important information for you. So I'm really happy to be working with my colleagues Today, Dr. Catherine Madison and Dr. Joshua Biddle. We're going to cover a number of things. Included in our agenda for today is going to be some of the progressive changes that we see in individuals who are living with a dementia diagnosis. We're going to talk about the elements of care planning that need to be considered for folks who are experiencing serious illness or anticipating that last chapter. And how to live well during that time is really kind of how we think about this process in our care planning. And then we're going to talk in specific detail, being guided by Dr. Biddle, about the differences between hospice and palliative care and the importance of palliative care for individuals who are navigating their lives with serious health conditions and all the different aspects of medicine and wellness that come into that conversation. So that is a little bit of a preview. And at this point, I'm going to hand the microphone over to Dr. Madison, who's going to start our slide presentation. And then she and I will be discussing a number of things as we go through those slides. And then we'll be transitioning to Dr. Biddle, followed by our Q&A, which we hope will have plenty of time for that. So again, really happy to be here. And let's go ahead and get the slides up, Sarah. Thank you.
Okay, there we go. All right, that looks familiar to me because this is a topic which I cover a lot. And thank you all for joining us today to talk about something which is the elephant in the room that we never want to discuss. And that's planning ahead for a good ending. But we need to understand the details around that. And I'm going to need you to, there we go. I'm sorry. Did you advance that, Sarah, or did I?
Yeah.
Okay, so I'd like to start with some groundwork. As all of us age, we get worried about those quote unquote senior moments. So let's talk a little bit about what are normal changes in our brain with aging. We all accept that we get changes in our skin with aging. We get blemishes on the skin as it's exposed to sun, and that's oxidative stress. We get similar changes in our brain. Oxidative stress can cause damage to nerve cells. And as nerve cells drop out, some of the connections of nerve cells or neural networks in our brain can slow down. And that leads to more of the tip of the tongue phenomenon. We've got the word, but we can't quite come up with it. It's there, but it takes more time for us to bring the word out. We also have more trouble with multitasking. And so all of us women need to just cut back on that demand of ourselves, or we're setting ourselves up for failure. And then, of course, we have more trouble with our eyes and our ears. So we're getting less sensory input to keep our brain on top of everything. And with aging, we have increased risk for side effects or toxicity with the medications that we may take. So I think it's good to lay the groundwork there. Yes, there are normal changes with aging. So then on the next slide, let's see. I think I need you to advance them for me, Sarah. There we go. Now I'd like to talk about something that you may hear about called mild cognitive impairment. So that term is bandied about by doctors, and mild cognitive impairment officially is a diagnosis made by formal cognitive or neuropsychological testing. It's where someone has decline in some of their cognitive skills, such as their ability to remember information, their ability to solve problems, their attention, their language, their visual spatial skills, and their abilities in those domains or cognitive areas are below what would be expected for someone of a similar age and educational background. So this data is generated from looking at studying thousands and thousands of individuals. And that's why this is a formal neuropsychological diagnosis. Important here is that activity in your daily tasks is fully maintained. And that's when you have a diagnosis of a mild cognitive impairment, which may remain stable, or it can get worse and turn into the next slide, which talks about dementia. It's important to understand that dementia is a group of illnesses, neurodegenerative illnesses, where there are changes in or decline in our cognitive abilities that can include poor judgment, changes in your behavior patterns, loss of memory or forgetfulness, deterioration in language skills or complex thinking abilities, and that those changes are significant enough that it interferes with normal, independent, day-to-day activities or function. Alzheimer's is the most common type of a dementia. That's 60 to 70% of the dementias out there, but there are many, many other neurodegenerative illnesses, and research is only defining those further, which will help us when we come for specific treatments, but there are many other types of a dementia. So moving on to our next slide, I'd like to talk about what I think a neurodegenerative illness presents to us, and that is indeed an existential crisis, because I can't think of anything that is more terrifying and anxiety provoking than to know that you have a neurodegenerative illness, which at this point in time is not curable and is going to silently steal away our independent ability to take care of ourselves. And what is really, I think, one of the most terrifying things here is that it doesn't start suddenly. It's not like where you have a heart attack or a stroke and you know something has changed. This comes on very gradually. And the transition between a mild cognitive impairment and a dementia can also come on gradually, as people's abilities can fluctuate from one day to another. So with our next slide here, we're going to talk about what we would all like, which is a peaceful ending. I can't think of anything better than what I put on the slide here. And our biggest fear is what I put on our next slide, and that is ending up in a nursing home where we're only a shadow of our former selves. And there are many of us who don't want this kind of an ending. So what can we do to try and make sure that the last chapter of our life story turns out more like we want it to? So for our next slide here, we're going to talk a little bit about just trying to have some autonomy at the end of life. As I mentioned previously, decision-making capacity is slowly eroded with neurodegenerative illnesses and their dementia. And when someone is just given a diagnosis, at that point in time, they would have the capacity to decide how they want to end their life. And people think, well, what about, everything about, I've heard about that death with dignity laws and such. Well, when someone receives a diagnosis of a dementia, though, they typically don't have another life-threatening terminal condition, such as a cancer or advanced heart disease, that would allow them to participate in that type of planning. So now, right now, while we're cognitively intact, or at least close to it, this is the time to plan. So I want to move on to the next slide and pass things over to Dr. Duncan, who has more information on some of the specifics here.
Thank you, Catherine. So I just wanted to take a minute to highlight and help the audience to understand what medical aid in dying is, because that's one of the first questions that I get from folks who are speaking about their life with a possible future of dementia. Is, would I be able to participate in this option? And so I want to get that off our plate right away. The answer really is no. And for the reasons that Dr. Madison pointed out, at the time you receive a diagnosis of dementia, and even as disease progresses, most individuals do not simultaneously have another life-threatening condition. They may have many other conditions, heart disease, lung disease. They may even have a cancer diagnosis. But in order to participate in medical aid in dying and to engage with a physician provider to receive that kind of care, you would need to have a 6 months prognosis. And one of the things that we understand about dementia, of course, is that it has a very waxing and waning course, a very bumpy course with a slow progression. And it can be extremely difficult to predict how long someone may survive with even advanced dementia until they really are truly in the latter stages and they are no longer eating and drinking, for example. So because of the way this law is written and what is required for participation or for eligibility, individuals with dementia generally cannot participate. It is required that you be fully competent to make all of your own medical decisions and also simultaneously have a 6 months prognosis. And that is just really never the case for somebody with late stage or advanced dementia when we would predicting that they might die from their dementia illness. Next slide. So when we do think about, okay, then what are my options? And I want to provide some reassurance here. And as you'll hear from our other speakers today, you have many different options in the way you receive your care and in the type of care that you receive. And what we're promoting and discussing today is a very person-centered care where we put your life and your level of wellness and engagement and also your personal desires about how that should unroll should be at the center of how we give your care. So lots of different options. Early planning is very important, whether you're going to be facing a dementia diagnosis, which we don't even know about yet, or perhaps you're in the early phases of other conditions that may lead to a life-threatening illness at some time in the future. As we focus on living very well until your last day, which is how I prefer to think of it, rather than dying well, actually living well until, until that last moment, we want to plan early so that you have open communication and you have the support team in place to ensure that you will be able to achieve those things that are important to you. So talking about a peaceful and semi-autonomous end to life is very possible for individuals, even with progressive dementia. And understanding the differences between what hospice and palliative care are and when those should be engaged is really important. So we're going to circle around to that in a few minutes. Next slide. Before we do that, we want to talk about some tools that are critical for using or that may be helpful to use for you when you are thinking about how you want to document your care and how you want to involve those individuals around you who may be supporting you during illness. Next slide. So first, I have some information on the Advanced Healthcare Directive, which is a really central document. Most of us have one in place, and I just want to clarify what that is. So an Advanced Healthcare Directive generally does two things, at least most of the forms that are available today. They legally appoint a surrogate decision maker who will speak for you at a time when you are not able to speak for yourself. And I want to remind you that that time may come and go. We often fluctuate. A very severe acute illness, such as even a very traumatic accident, or let's say you're allergic to bee stings and you pass out for a short period of time and the ambulance is called. During those moments, you're not able to participate in your own decision-making process. And at that time, the medical system will look to a decision maker. And if you have a legal decision maker appointed in an Advanced Healthcare Directive, that is the person who will speak for you. If not, it will be a default, usually loosely described as next of kin, but for individuals who have many different family members, that can be confusing for individuals in the medical system, unless it's a direct spouse or a very clear delineation of someone who should be speaking in that role. That's why we strongly recommend that you designate who your Advanced Healthcare Directive spokesperson should be. The other thing that an Advanced Healthcare Directive does these days is it incorporates what used to be called the living will, which includes information that you provide about the type of care you might want. And it might include information about treatments you do or don't want in certain situations, or it may include none of that. And there are lots of different types of forms. Almost all of them, if they've been appropriately signed and witnessed, they are legal across state lines. So that's important to know. Next slide. And then we have the POLST form, which is a different document, also a very important document. It's used in a certain phase of illness or for certain specific situations. So I want to talk about the differences here. This is a document that can be filled out by a surrogate decision maker, but most often and more importantly, it should be filled out by the individual who owns the document. So this is your form that indicates whether or not you would want to be fully resuscitated if you have an immediate life-threatening event. It is a form that emergency services providers will be looking for if they're called to your home or to the hospital, something happens and a person has stopped breathing and their heart has also stopped. This tells the providers what they can do immediately, even in the absence of discussion with a healthcare decision maker. So it's a very important document. It is tantamount to a medical order that can be acted on. So I want to, I'm going to highlight a couple differences, but first I do want to mention that there are several sections of the form. I'm not going to go into a lot of detail today because we don't have time during this presentation, but there are lots of resources where you can learn about what this document is, how it can speak for you, and how it can support you to get the care that you want. And as always, you know, even though you make a decision at one point in time, it's possible to soften that decision to educate your care providers as well about when it might be time to consider another form of care. So that's why within this form, we have the option of having a period of full treatment, for example, before changing to something less aggressive potentially. Next slide. I included this slide to show you some of the differences between an advanced healthcare directive and a POLST. On the left there, you see that a healthcare directive is going to appoint a legal spokesperson. It's going to provide some guidance for future care decisions, and mainly that guidance is going to be acted on by your healthcare decision maker when they are speaking for you. There are lots of different types of forms. Most of them are legal if they've been properly witnessed. And we always want to interpret that form in context if there's information in there about the care that you want to receive, because it may have been written way in advance of the time that that document is needed. The most important thing it does is legally appoint your decision maker. That's very different from the POLST form, which is going to give very specific medical orders about the type of treatment you want, and it can be acted on in the absence of your healthcare agent. So those are some critical differences to be aware of. Next slide. Along with the POLST from the Advanced Directive, that are important tools that your healthcare agent can use to discuss and communicate healthcare desires and wishes. We also have other tools that you can use with your family and with your healthcare agent to help yourself and others discover what is important to you. So I'm going to pass this back over to Catherine for a minute. She's going to talk about the Go Wish cards, which are a tool that we both use very often with individuals and families.
Well, I think it's really difficult getting this conversation started. As I said earlier, this is the elephant on the table that nobody wants to talk about. So I'm a big fan of conversations over the dinner table. And so I will advocate that people get these sets of cards which put priorities on them. And so you go through this deck of 36 cards, and each card has a saying on it, ranging from what you see on the slide there is to have my family with me. And there's another card that says to be alone. And so whether it's having your family with you is important to you, whether having, someone of your religious preference with you, being in your home, those are all things that you can talk about with family members, and it simply gets the conversation started. You go through these cards and you sort out what are the 10 most important to you, what are kind of middle of the road, and which are your discards. And then you go through your pile of top 10 again and take your top however many picks out of that, your top 3 or 4 picks out of that, and you compare cards. They come in different colors. And so you can see how everybody's preferences, what's most important for them at the end of life, can be different. And that really helps with this conversation. On the next slide, Lael included another one which is available in Chinese, which is called Heart to Heart. So there's lots of different ways to get this conversation started. And I think doing it with cards and presenting it as just a game at the dinner table is the best way. So expanding on what was talked about with Advanced Healthcare Directive, I want to bring up something that was specifically developed as a dementia directive. This is very confusing because I know we're throwing a lot of documents at you. They actually all kind of layer on each other and can be used at different times. They're all part of this communication. So the Dementia Directive was developed specifically as a tool to help individuals prioritize what their goals of care would be if or when they came down with a dementia, a neurodegenerative illness. And so what it does is it has separate pages putting broad definitions in place for what is early stage, mid stage, and late stage dementia. And what would your priorities for care be in these specific points in the course of a dementia illness? And so on the next slide, I actually condensed the points from one of those pages. For instance, in each page, it will describe just briefly, what stages are. A mild dementia is where people lose the ability to remember recent events in their lives, and routine tasks such as cooking or driving become more challenging. If you were at that stage in a neurodegenerative illness or dementia, what level of medical intervention or treatment would you want? You could choose, and this is similar to the POLST, you could choose to live as long as possible with the breathing tube and chest percussions. You could choose to receive treatments to prolong your life, but you don't want your heart to be shocked and you don't want to be placed on a breathing machine. You could say that you don't want to go to the hospital, even if you were extremely ill, you would want to stay at home at all costs. Or you could say you want only comfort-oriented care. And in my experience in working with patients, indeed, when people fill something like this out, they will fill out this page differently for the different stages of a dementia. And just a reminder for everybody in the audience, we have a PDF of our presentation here available, so you will be able to get links to all of these documents that we are referencing. So on the next slide, though, I'd like to talk about something which makes this conversation a lot more complicated when you have a neurodegenerative illness. I've got a medical term there called anosognosia. So anosognosia is a medical condition that happens when there are changes in the brain such that an individual cannot see changes in themselves. And it can happen with strokes, but unfortunately, it happens a lot in people with dementia. It is severe in almost a third of patients with Alzheimer's disease, and I would posit that it is present to a variable degree in most others. Family members can interpret this as denial. They'll say, oh, well, she's simply in denial that she's having trouble. And I will try to point out she may be having some denial, but there is likely an element of lack of insight or anosognosia present. So when someone says to me, oh, Dr. Madison, I walk a mile every day, and I have a daughter in the background going, no, like this, I need the daughter or the other family member to understand in this patient's mind, the fact that she walked a mile every day 1 year ago is in her present tense. There's a different reality going on here. And that makes these kinds of conversations much more difficult. It makes it harder to get an evaluation. It makes it harder to do the planning. And once again, we circle back to you have to plan early. On the next slide, I simply bring up a point of prospection. And this is goal-directed behavior, like when one of us is going to plan how we're going to celebrate Christmas this year. To put that together, we have to think about Christmas last year. Who did we invite last year? What did we serve? What went right? What went wrong? Who's coming this year? Who's traveling? So that's all based on conditionals, and it's referential thinking, comparing a lot of different things together. And as people have loss of cells and breakdown of some of those neural networks, that kind of communication and problem solving breaks down in the brain. So when a loved one says to you, I'll get help when I need it, they may have lack of insight into the fact that their home is a mess right now and they need it right now, and they are unable to participate in this kind of goal-directed thinking to figure out when exactly to put it into place. So understanding that this is going on in the brain of an individual with a neurodegenerative illness, or most of them, is very important for the rest of us to understand while we are trying to get this conversation going and to make plans. So for our next slide, I simply wanted to put out very briefly that there can be addendums to an advanced healthcare directive. And I have one that I condensed on the next slide that I share with people that I meet, where I highlight just a couple important points. I have done this for myself. All of my kids know it, as my one daughter said to me, kind of morbid, Mom, but you're right, it's important. And I want a peaceful and timely death. I don't want any disease-directed treatment that could prolong my living or my dying. Don't ever coax or force me to eat. Let me eat whatever the heck I want. I don't want any tests done to try and find an illness to treat, but I do want to be kept out of physical pain. So you can add addendums. And on the next slide, Dr. Duncan, I think, is going to talk about one which she also likes. Lael?
Yeah, thanks, Catherine. So there are many different ways to do this. And one of the ways that I like and often share with people is simply to write a letter to your family. And I think Catherine's addendum to her advance directive is a perfect example. A letter to your family, including your hopes, wishes, concerns, and possibly fears, should you be facing a severe or advanced neurocognitive illness, to put that in a letter and attach that as an addendum to your advance directive puts it into the hands of your decision maker for when they would be acting on those choices. So very important that they have that information. It can be challenging, as we've mentioned, to sit down with a blank piece of paper in front of you and think to yourself, oh my gosh, well, don't know what my choices are really, or I haven't thought about this before. That's where some of those decks of cards come in, helping you frame what some of your choices might be or think about the topics. There are other ways to do this, and you're going to get a list of resources from Sarah after today's presentation. This is just one of them. This is called the Stanford Letter Project. It is an online tool where you get prompts and get information about how you can write one of these letters. So a lot of information on that website, and there are other resources like this that we will be sharing with you through Sarah. Next slide. And I think that brings us to our transition over to Dr. Biddle's presentation. So we're going to pass the microphone over to you, Josh, and let you get started talking about these very, very important concepts.
Wonderful. Thank you so much for that amazing presentation. I'm excited to be here with you all today and meet you and talk a little bit about palliative care and compare and contrast that to hospice, and then like we said, hopefully leave a lot of time for questions and discussions afterwards. So my name is Dr. Joshua Biddle. I'm the medical director of outpatient palliative care here at Marin Health. And you know, I kind of wanted to start off by just saying that everything that Catherine and Lael have gone over is incredibly spot on, incredibly right. And as people can see, it's a lot, you know. Navigating end-of-life care for any person can be challenging, let alone if you do have an advanced neurocognitive disease. And so, you know, I really am a little bit biased, obviously, but sort of introduce palliative care in that vein, that we are the people that can kind of help navigate that for folks and their families. And really at the heart of our philosophy is this idea that we really do try to see the person beyond the disease and the family beyond the disease. And I think while many doctors, that's not to say other doctors don't do that as well, I think it really lies at the heart of our philosophy, and just really thinking about people's journeys in terms of their human experience, of which their disease or dementia is a part of it, but not the thing that defines them totally. And so that's really kind of where we begin, and all of our services are oriented towards that. Next slide. And so this is a really good definition of palliative care that I think most palliative care providers like. It's put out by the Center to Advance Palliative Care, CAPC, in 2019. And they say palliative care is a specialized healthcare for people living with a serious illness. This type of care is focused on providing relief from the symptoms and the stress of illness. The goal is to improve quality of life for both patients and the family. Next slide. It's provided by a specialty trained team. Palliative care specialists work together with patients and other doctors to provide an extra layer of support. And palliative care is based on the needs of the patient, not on the prognosis. It is appropriate at any age and at any point in a serious illness, and can be delivered with curative treatment, curative or standard treatment. And so, obviously that's a lot there, and that's a lot to unpack, and we can go into that if people have specific questions. But I think one thing to notice is that a lot of those terms are fairly broad and even vague to a certain extent. And I think in some ways that's a little bit by design. We want to create sort of a large welcoming tent for folks and families to feel like they can come have a conversation with us, and really get their needs met, sort of regardless of what they're going through. I'll maybe touch on that a little bit more, but essentially we can meet people from the time of diagnosis, the very beginning of diagnosis, all the way up and through the end of their life. And so it really is a broad tent, and certainly dementia and other neurocognitive diseases fit squarely within that purview. In addition to doing, I see a lot of different patients, not just dementia, but also people with cancer and things like that, and do symptom management and a whole host of other things. But again, what we're really trying to get at is just making sure that the care you get as a patient and family really matches what's most important to you. And being thoughtful and thinking through, does each intervention match what you ultimately want, as outlined beautifully by Lael and Catherine. And also to recognize that it's, much of healthcare is oriented towards the patient, rightly so, but that it really affects the entire family, especially a disease like dementia, which can be obviously challenging for the person, but incredibly challenging for their loved ones, their spouse, their broader family. And as people and families experience various losses over time, we just absolutely make sure to include the entire family as the unit of care. Next slide. And the way we do this is as a team. Thankfully, we're very lucky in Marin to have a fairly well-resourced palliative care service. We have both an inpatient service at the hospital led by Dr. King, and then I lead the outpatient palliative care service. And in both places, we have physicians, we have nurse practitioners, we have nurses, we have social workers, we have spiritual counselors, we have clinic coordinators, and that's both for the patients and for ourselves to support each other. This work can be challenging, and we call on each other and each other's expertise to kind of help give you what you need. And the other thing to say is this can maybe look or sound a little bit overwhelming, and people might say, well, I don't need all of those things. I don't need a doctor, I don't need a social worker, I don't need a spiritual counselor, or I just want one and not the other. And I really just bring this up to say this is sort of the full menu of possibilities that you have at your disposal, but certainly you don't need to see all of us, and we can really tailor our practice for what any individual family or person needs. And then really, this is what we're doing. We're thinking about people's physical, physiological, psychological, social, spiritual, and emotional well-being, and addressing whatever comes up at any given time. Next slide. Oops, is that blank? Oh, wow. All right, I put in, I didn't realize there were these, but yeah, this is, some of the common diseases that I see are, folks with dementia. You can see their cancer, heart failure, liver, kidney, or lung disease, ALS, people that have had a severe functional decline, multiple hospitalizations. Again, that term life-limiting illness is fairly broad, and we sometimes I even say it so broadly that we just help people navigate tough stuff. and people that are really experiencing a lot of life change in a short amount of time and are kind of struggling to make sense of it all. At the very least, we can meet folks and help ground them and contextualize their illness in the context of their broader life, and then titrate our intervention appropriately. Some of the diseases that are less well suited for a primary care service are things like hypertension, diabetes, cholesterol, other reversible types of infection. Those would be things that are probably better served by a primary care doctor. And then other chronic pains that are not specifically related to a serious illness is just not, my expertise, and usually not the expertise of other palliative care doctors. And that's when we might want to get other folks involved. But for the most part, people that have one of those diagnoses on the left would be a perfect patient and family to be seen in a palliative care clinic. Next slide. This is another way that we kind of articulate what we do, is we talk about ourselves as being an extra layer of support as people navigate their illness. And what that means is that, at least in the palliative care specifically, you really don't have to give anything up to see a palliative care provider. We see people in addition to their primary care doctor, in addition to their neurologist, in addition to their cardiologist, in addition to all the other standard of care a patient and their family is receiving. We come in as just an extra layer of support to supplement all of that other care. And so we provide support to patients, we provide support to their families, we provide support to their other providers, and can really be there to connect the dots and listen and make sure that people are getting what they need, and just sort of navigate that whole landscape for everyone involved. So it's just a reminder that it's not an either or. It's not like by seeing a palliative care physician, something is going to be taken away from you, or it means something inherently like, you're not going to get this care, you're not going to get that. It really is all additive to the care you're already getting, and is not, it doesn't mean you can't continue to see all of the other providers that you're already seeing. Next slide. This is, again, just to reiterate that it's really for anyone at any age, at any stage of their illness, and can be provided alongside all of their other medical care. Like I said, some people I meet right at the time of their diagnosis, you've just seen your neurologist, you've just been diagnosed with dementia, there's a considerable amount of emotional overwhelm or unknowing, or what does the future look like, or what are the resources available. And we can meet people right at the beginning of their journey and help kind of orient them. We can meet folks in the middle of their journey and hear about what's happened in the past, and again, try to plan for what's going on in the future. And then sometimes we meet people later in their journey when they've maybe been to the hospital 3 or 4 times and don't know if they want to go back again, and are looking for some help in terms of how to plan for the next step. So we really can meet people at any age receiving treatment anywhere along their process and journey. Next slide. There's a lot of studies that I won't bore you with that basically just show that palliative care works, thankfully. We definitely can help patients and family improve the quality of their life. We can work on symptoms. We address the spiritual, psychological, and emotional aspects of being a human being and aging and navigating tough stuff. And then where the rubber hits the road, if we do our jobs well, hopefully we help keep people out of the hospital, help them get the care they want in the place they get it, and help relieve some of the burden that their loved ones and caregivers can experience. Next slide. And now, sort of, for many folks at some point along their journey, they need even more help in the place they want to be, even more help than a palliative care service can provide. And so that's kind of why I wanted to introduce this concept of hospice and contrast it to palliative care a little bit. Hospice, in some ways, like palliative care, really first and foremost is a philosophy of care. And it really, more than anything, is focused on comfort. Focused on the comfort of the patient, wherever they are, wherever they want to be, and just really prioritize that almost over anything else. Often in the place like Marin, most folks that I work with want to end their life at home. There certainly are exceptions, and we can talk about that too. But for folks that are nearing even more the relative end of their life, that know they want to be home, know they don't want to go to the hospital, know they don't want to get poked and prodded, hospice is really the best way to take care of you at your home or at a nursing facility, or really wherever you want to be when comfort is the true focus of the care. It also is an insurance benefit. It's covered by all major insurance companies, Medicare, Medi-Cal, and really all insurances in between. And because of that, it does have some, special nuances that look a little bit different than care that came before. And then finally, it is a set of services, a really sort of regulated and prescribed set of services that patients and their families are eligible for, which I think I have a slide or two about if you coming up. So next slide. So right, this is just to show that, these two things are different. Palliative care is sort of the broader field of symptom management, advanced care planning, taking care of the psychological, spiritual, emotional aspects of serious illness, and is quite broad. It can be provided at any time along the disease course, along with any other care that a person was receiving. And then hospice is kind of a subsection of that broader field of medicine that is focused on comfort-focused care in the place where the person needs to be. And because it is a insurance benefit, has some nuances associated with it. Next slide. Again, with the animation that I didn't realize was there, I'm sorry. So this is the set of services that hospice provides. In some ways, it looks like palliative care, and that it has this interdisciplinary team. There are doctors, nurse case managers, social workers, chaplains, volunteers, home health aides. What's nice, again, is that it can be provided wherever the person wants to be. Most folks are at home. Some folks are in a nursing facility. There are other inpatient options for palliative care. One of the main benefits of of hospice is that it has a 24-hour sort of nursing call line, whether you're at home or in a nursing facility or anywhere else. If anything arises that needs to kind of be addressed in the moment, you can call the nursing hotline 24/7. They can either walk you through things on the phone or kind of send an on-demand nurse to your house to evaluate things there with a little more nuance than if you weren't on hospice, which is oftentimes just calling 911 and going to the hospital, which is oftentimes something that folks don't want to do, and in many cases is not helpful and can just be kind of destabilizing to the situation. Most folks start with care at home and end with their care at home. If that's not enough support and people need more help, they can always transfer your level of care either to a facility or an inpatient unit. The beauty of hospice is they prescribe and provide all medications. You never have to go to the pharmacy again. They bring the medications to your house. They provide all medical equipment that is needed: hospital beds, commodes, wheelchairs, oxygen machines. And again, with one phone call to the hospice number, they order that, they deliver it, and it really is just a lot of support. What they don't provide at the home is sort of 24-hour around the clock care, which is sometimes can be something that folks with dementia need, and that is really unfortunately oftentimes either provided by family members or you have to pay for it out of pocket, which can be sort of financial burden and cost prohibitive to folks. But they do provide 24-hour on-demand nursing support with home visits sort of as needed, but not just sort of that day-to-day cooking, cleaning, that kind of support. So it is, if you go back one slide, I didn't put this in there, and I can bring it up if through questions, but because the care is so comprehensive and sort of oriented towards comfort and being at home, oftentimes what it doesn't provide in most situations is things like lab draws and imaging and other sort of more interventionally oriented medical care. Sometimes the misconception is they don't treat anything when a patient's at home, which is not true. You often can continue the medications you've been on prior to hospice. You know, if there are interventions that are in the vein of supporting someone's comfort, they certainly will do that as well. And if you have something like a urinary tract infection or pneumonia or something that could be reversed with antibiotics, and that's within goals of care, they will come out to your home and evaluate you clinically and make a clinical diagnosis and treat those types of things in the home without having to go to the clinic or getting labs or going to the hospital and doing all of that. So that's hospice. And then next slide. This is just kind of to talk about our service here at Marin Health in particular. Like I said, we had both an inpatient and an outpatient palliative care program. Unfortunately, we just don't have the staff to have a home-based program at this time. By the Bay Health, which used to be called Hospice by the Bay, does have a home-based palliative care program, which I can answer questions about if folks have that. Here in my clinic, we do in-person visits, we do video visits, we do telephone appointments. You know, the clinic is myself and one nurse practitioner, one social worker, and one spiritual counselor. We just unfortunately don't have the bandwidth to do recurrent home visits, but if occasionally someone is really unable to leave their home and can't use Zoom and is just really having a tough time getting to the clinic, sometimes I can occasionally do a one-time home visit to kind of assess the situation and see how best we can support folks. And then, you know, it usually is helpful to get a referral from either your neurologist or specialist or primary care doctor. If you get a referral from one of those people, I think 99% of the time it's covered by insurance. That hasn't really been an issue for folks. And so that is the most helpful. And then there's just other services here. We have nutrition, psychosocial counseling. There's an integrative wellness center that has meditation, body work, massage, acupuncture, shinjitsu. And then this is how you can kind of get a hold of us in our clinic if you want to reach out. But very, very nice to meet everyone. And I look forward to the conversation. Thank you.
Thank you so much, Joshua. And I'm going to switch it back to, hold on, let me stop the screen share and take care of the logistics here, as I want you to be able to see all three speakers as we go into our Q&A. Dr. Duncan,
yeah,
is that where did you have some things you wanted to wrap up with before we do that?
No, that's fine. I think we can start discussing the questions. And, you know, I had made some notes about additional topics we may want to cover, but I think there are a couple of short answer questions right already in the chat lane that I see that
yes.
we can take care of pretty quickly. So how to access palliative care, Josh, I think you just addressed that. You really just need a referral from your primary care provider. And in a very elderly person, individuals advancing into their 90s or beyond, they often have functional decline issues that make them eligible for palliative care evaluation. And is there anything you'd like to add to that, Dr. Biddle?
No, I'll just say, and I think most folks here are in this county, but I know Kaiser has palliative care.
Yeah.
Marin Health has palliative care. Most of the major health systems in the Bay Area have palliative care services. And you really just have to ask for it. You know, you kind of do. Sometimes you have to be an advocate. You know, as our culture of medicine changes, all providers are kind of on board with palliative care. But if you do meet any resistance from a doctor you see, you kind of just have to advocate for yourself a little bit. And the referral could come from your primary care doctor, your neurologist, or any other physician you have. So you just keep bringing it up and yeah, get a referral. And if that doesn't work, you can call our clinic and we'll help you figure it out.
Sounds good. Thank you. Thank you for that. So as we mentioned earlier, the slides, the bios for the speakers, as well as a handout of resources are all going to be made available to you. The recording will be up on the YouTube channel on Friday for individuals who are looking forward to that. And of course, then it can be shared with others. So I'm going to come back to you, Dr. Biddle, and ask, you know, can you expand a little bit on some of the psychological supports that are available through palliative care services?
Yeah, I mean, in our clinic, we have a social worker a licensed clinical social worker, and we have a spiritual counselor, and both of them are available to talk with either the patients or the patient with their family or the family alone. I think we have patients and families that see either or both of those people in all iterations. So, typically we don't have the bandwidth to kind of provide weekly ongoing therapy for folks, but there are some patients that see the social worker and the next week see the spiritual counselor and then see me. And, we kind of get people what they need. And then if people need more ongoing sort of weekly therapy, we can refer folks to other clinicians in the community and just try to make it work. But yeah, we both of those people offer support, psychological support to patients and families alone or together. And even after death, we have some family members that continue to see our spiritual counselor months and years after their loved one has died.
Yeah, indeed. Grief and bereavement are very complex processes, and depending on how the death event occurred and what led up to that, there may be some things to work through in that aftermath. So that's important. We all understand, and I'll ask Dr. Madison to comment in just a minute, but certainly we're all very aware that serious diagnoses such as we've been talking about today, and certainly for, dementia among them, lead to levels of anxiety and depression that can be challenging to navigate for individuals, for families, for caregivers. There can be physical and emotional exhaustion. There can be stresses that wax and wane, and to have someone to speak with about that, and then importantly, to be able to get that medical evaluation in case you do need specialist psychiatric care for, say, a severe unrelenting depression or something else that's coming into the picture. Your providers and the leader of the palliative care team or the leader of the hospice services team, they're going to reach out and be able to connect to those supports. And that's just really important. And maybe Dr. Madison, you could comment on that and kind of how you see that with families with dementia and what they might be experiencing.
Well, I think one of the most important points I tried to get across when talking about dementia and neurodegenerative illnesses is that these diagnoses aren't solid lines of black and white. It's not like a heart attack. And so the important thing to understand is just that it can vary and it takes a while to come up with a diagnosis. Don't get upset because the doctor didn't say the diagnosis out loud. We all have a lot of stigma and fear about terminal medical conditions, and I think dementia more so than even others. And I got to tell you, from the medical side, doctors themselves have trouble with these conversations. Dr. Duncan and I have both talked to residents. I'm sure Dr. Biddle does the same thing about how to have these conversations and teach doctors how to bring up topics like the POLST and end of life priorities. So dementia just makes it more complicated because the person who has the illness may very well not see the same reality you are seeing.
Yeah, and not that they can't participate in the conversation. Very often they do, and most often they do. But there may be some critical decision points, of course, where they need support because they'll lack the ability to have the insight for that more advanced decision making. Thank you. There's a simple question about the POLST form. So a POLST form is something that you just discussed with your provider. Usually it's your primary care provider, but if you're being seen by a cardiologist or a kidney specialist or somebody like that, they also should have access to a POLST form. The reason you get it from your doctor is because the doctor has to sign it. Remember, it is a medical order. It is a form that will put orders into place in the event of a life-threatening event. So it is available through your provider, but you certainly can read about it and look at it online. Lots of resources for that. California POLST program is very strong, one of the most robust programs in the nation. Actually, it's a founding program and has been modeled across the US. I want to come back to Dr. Madison a little bit. I think people are often confused about how dementia becomes a terminal illness and what that pathway looks like. And as you know, I always think of there is a long pathway and there are lots of rocks you might trip over. You just don't know when that fall is going to be the last fall, or when that fall is going to be the fall that means you need to kind of look differently at how your care is being delivered. And I wonder if you could speak a little bit about, why dementia, which has a huge, big spectrum of severity, how does it become a terminal illness for people?
And I think what I'd have to start with is that every single case is unique. I have people ask me all the time for a prognosis, and they want a timeline, and I can give broad generalizations, but I always have to emphasize every single case is unique. As Dr. Duncan said about, rocks in the way and stumbles, I look at it more often as a type of a decline which can go in a plateau for a while and then have a downslope, and then it may plateau for a little while. It may have more of a gradual downslope, but it could still always plateau. And the transitions, once again, are gradual. I tend to think that when people stop eating, that may indeed be their brain, which is deteriorating, sending a signal out to the body, it's time to shut down here. What we all naturally do, it's like an instinct for us, is we want to feed our loved one. And so what oftentimes happens to people with a dementia is that family members first start making the meals. It's not uncommon that people with a dementia start losing weight. They forget to eat. And again, I think, is that the brain sending a signal out to the body? We're reaching the end of our story here. So that, I think, we can subvert the normal end of life by inadvertently intervening and feeding people. Once we've started to do that, I've seen individuals stay alive for years. They become physically more frail, and they become more dependent on others for care. When they stop feeding themselves, they often will stop with daily activities and care, such as bathing and showering. They might need, diapers because they can no longer control their bowels. They have to be dressed. They have to be turned. The care level, as Dr. Biddle was mentioning, someone in the terminal stages of a dementia, they can need 24-hour care. So I think we need to keep in mind that it's a slippery slope, and I keep coming back to planning early. And I hope I answered your question there.
Yeah, that was very helpful. And I'm going to engage Dr. Biddle for a moment as well. So you talked about a series of declines followed by maybe a plateau. And of course, a lot of these are inflection points. Sometimes the decline is a hospitalization or acute illness, after which we see a further decline. And then again, maybe that plateau. And it can be very, very difficult to know, well, gosh, where are we on this person's trajectory? But that gradual withdrawal from food intake, which can be subtle at first, and even while people are still fairly interactive, is a sign that's important. And those conversations can be challenging, because now we're talking about balancing someone's quality of life and perhaps their enjoyment of eating with their longevity and how they're otherwise feeling, and whether or not there are concurrent illnesses that may be impacting that pathway. And so, Josh, I wonder if you could say a little bit about kind of that complexity of navigating that conversation, and what advice you give to families who are trying to understand how to make feeding decisions for an individual with an advanced dementia illness.
It's a great question. Yeah, complicated question. I think, because I do want to step back to something what Dr. Madison said, which is, this is a process, not even diagnostically, but as things evolve, it's a process, and it's individual. I mean, there are similarities, but it's individual for every patient and every family, and, what can happen and what doesn't happen. And, what you really are looking for is someone, a healthcare provider that you trust and know, to help ride those waves with you, because I think it's so crucial to have some general North Stars about what a person wants and what they don't want, and have a plan and then also know how to implement that plan as the rubber hits the road and things are happening in succession. And so the reason it's hard to answer specifically because it is a process. I mean, what I do is I meet people, I get to know them as well as possible. You know, part of what makes this so challenging in our healthcare system is that these are nuanced, complicated things that take time. And oftentimes, as people know, their other providers don't have enough time to really get into this stuff and listen for half an hour and come up with the plan and feedback and do all that. And so what we do is we get to know folks and their families, spend a lot of time talking with them, a lot of time understanding what's important to them, what their goals and what their values are, what the journey they've been on before, what our best guess of what the future might look like, what the plan is, and then, you know, project into the future as best as possible, and then also be available for that just-in-time care as things come up. And so how I frame it with folks, rather than try to answer a specific question about should you feed or do this, it's like there comes a point in a patient's care when the question is not what is the right thing to do. The question, you know, there are many loving things that people can decide for their loved ones based on how well they know what their goals and values are. And we really just try to help people come up with what feels like a loving decision in the moment based on what's available and what the limitations are, and just hold people through the process of making what can feel like difficult decisions. And as long as we're doing that in a way with resonant with who this person is and what they want and what's legal and what's ethical and all of that, we can, you know, there's a whole host of different decisions that can be made.
Yeah, thank you so much. And, you know, I hope people are getting the sense that it isn't one pathway, it isn't one checklist, it isn't that you can plan for everything right now. Planning is an ongoing process, and having these conversations with your family and with your decision maker is an ongoing engagement, really, because circumstances change, our sensibilities and our feelings and our perspectives change. And as we progress and navigate through these challenging times, what we want and what we care about can shift. And so having those open lines of communication, understanding that you have done the groundwork with some initial planning and some general thoughts about what's really important, what you might want to avoid, etc., gives everyone a framework to start with. And I think I hope you're hearing that as our speakers are talking. I do want to do a time check. So we have about 5 minutes left. I want to touch on a couple of questions here that have come up. So there is a question about a death certificate. I'll go ahead and take that. So individual is wondering, because of veteran services benefits, there may be difference in benefit allocation based on the death diagnosis. Excuse me. And what can I do about that? So you want to talk to the provider, hopefully in advance of the death event, so that they understand that this may impact your the outcome of the benefits decision, because dementia could be listed as the primary death diagnosis, or there could be something else that's intervening. So if if the death has already occurred and the certificate is already being created, then the safest, kind of your direct way is to go back to the provider, discuss this with them, and maybe engage the county offices of life statistics where they keep the certificates, and find out what the process would be for potentially altering that. It is complicated, it is time consuming. I can't guarantee that there would be the outcome that you're hoping for, but there is a process for that. And I would discuss it with the provider, and then also at the county offices would be important. And Sarah or our team might be able to give you the link for that. There's another question about an individual. Josh, this might be for you, a 91-year-old individual with back pain who's had some recent life changes, including a move and a disruption to her pain management after some compression fractures. It sounds like she's in some clinical decline. She's got some mild cognitive impairment, and the family's just sort of struggling with how to stabilize what's happening for her. Does that sound like a good individual for a palliative care assessment?
Yeah, and I don't know where that person lives. I think they said they might have lived somewhere else. I mean, my bias is always yes. I think you can always get evaluated and should get evaluated by a palliative care team. It's hard not knowing all of the details, but it certainly sounds like there's enough going on that a palliative care evaluation would be totally reasonable. You know, whether or not that provider is going to be able to manage their ongoing chronic pain, I'm not exactly sure, and I can't speak for all different providers, but that person is certainly, hopefully, going to be able to contextualize things, either manage it themselves or point the person in the direction to get the treatment they need. So I would say absolutely yes. You should try to get a palliative care evaluation, and then those people can help, you know, navigate from there.
Thank you for that. Okay, and when we have time maybe for one more question, it's going to be a tough one, Catherine, and I'm gonna ask you to step forward first. But it's an issue that we all can speak to, which is when you're dealing with a third party who is either a friend to or a loved one for someone who is experiencing a cognitive impairment situation, and they are having this anagnosia where they are apparent denial according to what the family and friends might be seeing. Are there techniques or strategies that you can suggest to engage this person in ways that will help them to see or be aware that they at least need some kind of an assessment made, or that they may need to consider getting help? And how do we get into that space?
So I'm not sure if this is a question about the third party or the individual who has the changes.
You're advising a third party family member of someone
Oh, I see. Okay.
with cognitive impairment,
right,
who hasn't been willing to engage.
That is a really, really challenging one. What I have tried over the years is to remove or deflect focus from the person who has impairment and try and turn this into a team effort. So I myself, when I was, at the Ray Dolby Brain Health Center in San Francisco, I would see couples, and I would have like the well friend or the well spouse, get both of them to come in for a checkup and try to normalize this whole concept. And I've had some good luck with this. Nothing is ever guaranteed, but trying to take the focus off of the fact that this person has a problem, whatever strategy you can implement and make it a team effort for everybody to get evaluated, is my best advice.
Yeah, thank you. And Sarah, I think we're at time now, so I'm gonna bring you back in and for any final closing. But I want to say, on behalf of myself and the other speakers, of course, we're very grateful to all the attendees and to the great questions that you posed. You could tell that we probably could all sit here and talk until dinner time, I think, and there would be still more to share. But we're really, really happy to have been here with you today.
Oh my goodness. And on that note, let me just say on behalf of all the age-friendly leaders and our participants today that we are so grateful for the information that all three of you shared. And what a wealth of, I saw people taking notes. I'm sure people are ready to get the resources and the presentation slides and the recording, if that makes it easier for you. But what a lot of wonderfully helpful information for us, for our family members, for our friends, and those that love the people who are suffering with chronic diseases or dementia at this time. So we couldn't be more grateful for the fabulous presentation that you've put together today. So with that, I just want to thank all three of you again, and thank everyone for coming, and have a lovely, lovely day.
Yeah, thank you very much.
Thank you very much.
Thank you.
And Sarah, if there are questions in the chat that we didn't get to, can you please?
I copy all of them, and I will make sure we get those.
Okay, good.